Hello everyone, and welcome to this Open Hand webinar. This webinar is brought to you in association with the University of the Witwatersrand and the South African Society of Hand Therapists. My name is Nicola and I will be your host. The topic of today's webinar is tackling the tingling and everything else, effective therapy techniques for carpal tunnel syndrome. There will be a 45-minute presentation followed by a time for questions and discussion. And you can put your questions in the chat box throughout the presentation. If you have any questions about this or about anything else, then you can send us an email and we will get back to you. But for now, it's time for me to introduce you to our presenter for this evening. So it is my privilege tonight to introduce you to Sarah Ewald from Zurich, Switzerland. She graduated with a Bachelor of Science degree in Occupational Therapy from the University of Oklahoma Health Sciences Center in 1985 and has been working in hand therapy since 1989. She is a certified hand therapist and has a Master of Arts in Adult Education and Learning from the University of Phoenix. She has served in various roles on the international hand therapy scene and is a past president of the International Federation of Societies for Hand Therapy. She has published multiple journal articles and presented countless courses and workshops in many countries all over the world. She currently practices at City Hand Therapy in Zurich. I'm really looking forward to learning from her today. Thank you, Sarah.
Thank you. Hope you can see everything. I'm looking forward to speaking with all of you this evening. I did have a slide about me, but Nicole has done a wonderful job introducing me. Thank you very much. So we'll just move over to the aims for this session. We're going to review anatomy regarding the carpal tunnel specifically. We're going to look at carpal tunnel syndrome, how to identify this, some tools to evaluate it, treatment methods for it, and also quickly look at when conservative treatment with therapy is appropriate and when the patient should be referred on to a surgeon because the case is so severe. So by the end of this discussion, I did set up some aims as asked to do so. You should be able to correctly localize key anatomical structures on your own hand. So as we go through this, you might want to find these things on your own hand so you're familiar with them. I hope you're able to list the two most common symptoms of carpal tunnel syndrome and have two simple evaluation methods to go by so that you can correctly identify this and name at least two treatment strategies and a patient education tip for carpal tunnel syndrome. So carpal tunnel syndrome is the most common entrapment neuropathy of the upper limb. Entrapment neuropathy, it's a wonderful word. We talk about that a lot for other things as well. It simply means that the nerve is getting caught and compressed somewhere. It's also sometimes called compression neuropathy. The symptoms are usually within the median nerve distribution. Patients will complain of pain, tingling, numbness, and often weakness. Okay. Why? What happens when you compress your nerve? Well, the longer a nerve is compressed, you'll begin to see a reduction in sensation or an absolute absence of sensation if it's compressed for a really long period of time. The longer it's compressed, the more likely it's going to also affect the muscles that are no longer getting their electrical signal. And you may see some atrophy of the thenar eminence, which is that area right underneath the thumb, and the lumbrical muscles. The lumbrical muscles you can't actually see particularly well. They will not stick out, but their ability to extend the fingers will become, the IP joints of the fingers will become less pronounced. You may see a bit of a curvature there. Okay, these things combined, the decrease in sensation and the atrophy of muscles, ultimately can severely impact hand function. What you cannot feel, it's very difficult to touch, it's very difficult to pick up small objects as sensation recedes. And as you lose thenar muscle function, your thumb is a good 40% of your hand function. So your ability to move that thumb and get it to do exactly what you like begins to decrease. Okay. So carpal tunnel, if you take a look here at the image on your left, I've just put up a standard hand here. Your carpal tunnel is right here, kind of in the middle of your hand, proximal aspect of your hand, just after your wrist crease there. And here's your thenar eminence. Here is your hyperthenar eminence. And here, this oval thing is where the carpal tunnel is. You might locate that on yourself. The carpal tunnel is basically comprised of the flexor retinaculum, which is very thick, collagenous connective tissue band that connects the thenar area to the hypothenar area, and it builds the so-called carpal tunnel. The bottom of the tunnel are your carpal bones. So very, very inelastic, very tough, very hard. And inside this carpal tunnel, we have a lot of contents. You have 9 flexor tendons in there, and you also have your median nerve. I don't think the median nerve in this image is quite as perfect as I'd like to have it. I'll show you a different one in the next slide. But what I'd like you also to note here is you see here the hypothenar muscles and the thenar muscles, and they actually originate from the flexor retinaculum. That's where they start. And so that's also part of the area that it has to hold things in place. I mean, that's where they originate. And we'll come back to that a little bit later and the impact it can have. So looking at this in a little bit more detail, our compression takes place in the carpal tunnel. If we look at it here, you see the muscles, you see the layer of skin removed. Your thenar eminence, your hypothenar area. Here is your carpal tunnel, this fibrous band. And what you also see here, yellow going through here, is your median nerve. Okay. If you look at it here, this is another cross section. The median nerve is the most superficial structure within the carpal tunnel. Below it, you have your flexor tendons here listed at the side for you. And is also because of that it is quite, how should I say, likely to be compressed, because as soon as things get full in that tunnel, which the volume capacity of your carpal tunnel decreases when you flex your wrist and also when you extend your wrist, you're narrowing that tunnel. And the first thing that hits that flexor retinaculum, of course, is your median nerve. And you've all got up here to the level of your elbow, your funny bone. Imagine you call it, everybody knows that's quite a sensitive area. We're all careful. We don't really want to bang our elbow because the nerve is right there and it doesn't feel very good. And essentially that's what's happening here in your flexor retinaculum, underneath your flexor retinaculum. Your median nerve is right below that surface. It's also not very comfortable if you're banging up against that a lot. Okay. It's a natural bottleneck. I love that expression. It gets quite narrow in there. They're coursing along in the forearm. They come out into the hand and divide into several digital nerves. But within the carpal tunnel, it gets quite narrow. And there is a disproportionate amount of available space for the actual contents of this tunnel. And if any of these contents get a bit irritated or any trauma happens there, you're going to see an increase in the pressure within the carpal tunnel. So I came up with an example to help you understand a little bit how this is. It's not really my example per se. It is established within the literature. I just decided that I could explain to you what the amount of pressure was with using coins. And I use this illustration here at the side. So if you have 2.5 to 10 millimeters of mercury pressure within your carpal tunnel. That's basic what most of us have. It's pretty healthy in there. There's enough space, but there's pressure in there because, as we've established, it's a natural bottleneck. That's about the weight of somewhere between 1 and 5 stacked coins sitting on your carpal tunnel. Okay. As we would increase the number of coins and thus increase the amount of pressure within the carpal tunnel, if we doubled it, came up around 10 coins, we'd be increasing it to roughly 20 millimeters of mercury pressure. At that point, you're already going to begin to see some decreased epineural perfusion. The area around the nerve is going to have a decreased amount of blood flowing to it already with that little change in pressure. Now, if we increased it by 10 more millimeters of mercury, and it went to 30. That's now 15 coins stacked up on our carpal tunnel sitting there. We're going to already see at that point a decrease in the axonal transport. The speed at which a signal can cross that nerve is already going to slow down a little bit. If we increased it a bit more and add 20 coins to our stack of coins sitting on our carpal tunnel, we're going to begin to feel a paresthesia, that tingling that people often describe, or what we have surely all felt when we sat on the floor and our foot fell asleep, and you get up and then your foot is all tingly, it's getting quite numb, and it feels really, really weird. And that's actually nothing different than having your nerve to your foot compressed. As the blood comes back online, the sensation comes back online. If we continue to increase the pressure within that and go up to 25 coins, all stacked up, sitting on the carpal tunnel, then we have what's called epineural edema, meaning things are backing up and beginning to swell around that nerve, which will further increase the amount of pressure on a nerve within this carpal tunnel. If we get to 30 coins, all stacked up, that's quite a stack of coins here, but sitting on that single neural point, then we're looking at what's called intraneural ischemia. That means the blood isn't really getting through there. Our nerve is not really getting any more blood. And we have what's called a sensory and a motor block. That means basically the nerve, because there's so much pressure in there, is no longer able to transmit a signal. Just to give you some idea of what we're talking about there. So why does carpal tunnel happen? That's another really good question, and it's quite frankly one we don't honestly have the answer to. Most resources say somewhere between 80 and 90% idiopathic, meaning we just don't know. About 6 to 11% roughly can be a complication of rheumatism, rheumatoid arthritis. About 3 to 5% post-traumatic. Post-traumatic might be falling and injuring your hand and having some swelling for a period, or acute could happen. For instance, if you fell and broke your wrist, and there's usually immediately quite a bit of swelling and also some displacement of bones, that could also produce acute carpal tunnel syndrome. For a long, long time, we thought that if we had a lot of repetitive movement and it went back and forth, that must cause flexor tendonitis, and the tendons are swelling and they're pushing against the nerve. And actually, there's a fellow at CARE in 1992 published a nice study. He looked at that. They took 625 cases of idiopathic carpal tunnel syndrome, and they took tissue samples of the tendon sheaths when they were doing their carpal tunnel release. And they were thinking that they would find a lot of inflammatory cell, a lot of inflammation, and actually they did not. 96% just had benign fibrous tissue, a bit thickened, but there was really no sign of inflammatory cells there. And that's kind of an interesting thing. So it's usually not super acute inflammation. It could be something that's been there for a long, long time. And as a result, you see some thickening around the tendons, which is increasing the volume within that very narrow passage. There's also the factor of hormonal factors. More prevalent among women than men. Our hormone household changes a bit more, particularly if we're pregnant or going through menopause. In both situations, we do carry more fluids within our bodies, and thus this can also kind of push one into carpal tunnel syndrome. With pregnant women, it will generally resolve. It does not necessarily always resolve for menopausal women. Okay, so let's take a look now at the median nerve and the sensory motor branches, because here's a bit of anatomy that's kind of important. I like this illustration here from Drake, 2024, Gray's Anatomy for Students. And you can see here we have our flexor retinaculum. They've already removed our hypothenar muscles, so we're mostly looking at the flexor retinaculum. We see this yellow thing, which is the median nerve, and you can see it goes underneath the flexor retinaculum. Below that, you see are 9 flexor tendons with a common synovial sheath. At least it's a common synovial sheath here. Um, that's that cushion around the tendon. And what you might notice, it slides through, it divides. Our median nerve provides the different digital nerves to the thumb, the index finger, the third finger, and a good portion of the fourth finger. But what you might not have noticed is here, there's a bit that goes off before it goes through the carpal tunnel. And this branch of the median nerve is the superficial palmar branch. It actually innervates the palm of your hand. And that's an important sort of differentiating point if you're thinking, well, is it really down here at the carpal tunnel or could it be more proximal? You might always want to take a look at that sensation in the palm of the hand versus the digits of the hand, okay? It innervates this orange area here. Now, I will say I've talked with several surgeons about that, and they say, well, a lot of the time it is that way, but sometimes that sensory branch also goes through the carpal tunnel. So it's not a hard and fast rule, but it is generally reported this way. Okay. Once it goes through the carpal tunnel, the green area, as you see in here, both volarly on the palmar surface of the hand and dorsally, is the area that is innervated by the median nerve. Okay. The other thing that the median nerve also innervates is your thumb muscles, most of them anyway, your opponent's pollicis, your abductor pollicis brevis, and one head of the flexor pollicis brevis. In addition to that, it innervates your 2 lumbricals for your index and third finger. It does not innervate the lumbricals for your fourth and fifth fingers. Okay. So symptoms, let's take a little bit deeper look at that. When we're looking at symptoms, it is usually reduced sensation in the thumb, the index, the long finger, and half of the ring finger. So thumb, index, long finger, and half of the ring finger, the radial half of the ring finger, are areas that are innervated by the median nerve, and it is usually there that people will have reduced sensation and also report tingling. It is, as we've just established before, not usual for it to be reduced in the palm. They will complain of what's called nocturnal paresthesias. That means they wake up at night and their fingers are tingly or they're numb. They may feel like it's painful. Hey, this pain wakes me up at night. And they say, oh, I shake it and it feels better and I can go back to sleep. They will often also report that they're not able to do things as well anymore. It might be difficult to button a shirt. It's particularly difficult sometimes to pick up coins from a table or to retrieve things from pocket, to do fine motor things. And this is generally due to sensory loss. It's not as much a motor problem initially as it is a loss in sensory function. They will generally have a positive Phelan sign, and we'll get to that in just a minute. The other thing that you may see in severe cases, you may see some thenar atrophy. Here on the left, we have a healthy thenar muscle belly. You can see it's got a nice puffy volume. If you look at your own hand, you know, it's not really flat. It does have a nice curve there. But if you look at the hand here on the right, healthy one is on the left. In this case, the hand on the right here, you can see that's quite a bit flatter. There's not as much volume there. And that's a good indicator of what's called thenar atrophy. That means your median nerve isn't working particularly well because these muscles are no longer getting the electricity they need to function. At this point, if you see thenar atrophy, you will begin to see a decrease in pen strength. What you will generally not see is you will not see a lot of loss of grip strength. You may see a mild loss of grip strength, but your flexor muscles that are innervated by your median nerve are innervated long before the carpal tunnel. So they should still function. Okay. What I've also noted at this point, you may be thinking, well, she's talking about motor function. Why is she now noting 2-point discrimination test values? Well, 2-point discrimination is extremely slow to change. It is not a particularly sensitive test for carpal tunnel syndrome. And when you see atrophy, you most likely at that point, that's around the first time you're going to begin to see a decrease in 2-point discrimination values. And likewise, if you see a decrease in 2-point discrimination values, then you may want to take a close look at that thenar atrophy. It may be a little bit discrete at first. I'm going to jump now to a case example. Anna is a 52-year-old woman. She's been referred for general hand pain. And you might be asking yourself, well, we came to talk about carpal tunnel. Why doesn't she get referred by carpal tunnel? I live in the city of Zurich. I have a lot of patients that get referred with general hand pain, not from hand surgeons, but from general physicians. And they often don't always correctly identify carpal tunnel syndrome, and the referral can be very, very general. And it is often the therapist who will pick up and say, well, this is a little bit more involved than just that. So I've chosen that as this example. Anna works at a grocery store. She's married. She has 2 adult children. In her free time, she likes to make jewelry. When she comes, she complains of pain in her right and her left hands, and that wakes her at night. That's my first clue that this is maybe not just general hand pain. She says her fingers feel numb. She has difficulty making change when people pay by cash. She has a difficult time picking up the small pieces that she needs to make jewelry. Further questions for Anna. Does she also have neck pain? We're going to ask about neck pain because we want to be sure that we can kind of screen for cervical radiculopathy, meaning that the pain would be coming from the neck. We also want to ask which fingers is it exactly? Which fingers are bothering you? The thumb, index, and middle finger are what we're looking for. Patients will often say, oh, all my whole hand's asleep. But when you begin to look a little bit closer, it's usually not the whole hand. It's your thumb, index, and ring finger. Those are your 3 primary fingers for grasping, and that may feel, that's what becomes most apparent to them immediately. We might also ask if they could describe the pain. When does it happen? What makes it worse? What makes it better? And here we're looking for that clue that says, oh, I shake it and it feels better. That is often a very classical sign of carpal tunnel syndrome. We're also looking when we ask her, when does it occur the most? Usually at night, it wakes her up. And often after strenuous activity, when that volume in that tunnel gets a little bit narrower. We could be more precise in evaluating her pain. We can use a pain gauge, ask her to localize it specifically, ask specifically when it happens, also what relieves it, and we could quantify this as well. Generally, this is not an extremely painful condition. It's not usually acute, intense pain that drives the patient to seek help. It's more of the irritation, the tingling. So it can be a bit tricky. Very rarely have had a carpal tunnel patient say, oh, the pain is 7 or 8 on a scale of 0, no pain, 10, a lot of pain. They're usually coming in around, 3 or 4, and they'll say, oh, it's not always there. It's really weird. It's a weird feeling, but it's not necessarily always there. Now, the next thing we're going to do is evaluate Anna with some clinical tests for carpal tunnel syndrome. We mentioned Phelan's test before, which is the most classical one. You could also use a Tunnel sign or what's called Durkin's compression test or a scratch collapse test. Okay, I'll walk through these. Phelan's carpal tunnel test, as you can see here, was originally described in this manner, which is actually how I initially learned to do this test. You put the wrists in maximum flexion for 60 seconds, and the test is positive when the fingers begin to become sleepy or numb or tingly. Okay. We no longer do this test in this manner. Because when we are flexing the elbows like that and asking the patient to hold, we're also usually compressing the ulnar nerve in the cubital tunnel in this position, and that only confuses things. So we now do this test with the elbow straight, and the therapist can bring the wrist into flexion and hold it there. Make sure you use a stopwatch and really keep track of your time. And the moment it begins to tingle, you want to note that down. It gives you an idea of how reactive or how irritated that nerve is. If it does not tingle, the test is negative. Okay, two other options. Tinel's test, you simply tap along the distribution of the median nerve. You're looking to elicit that funny bone feeling that you would have had in your elbow, that tingling there. Thing to remember about Tinel's sign is it is often also, it's sometimes in healthy people, not that difficult to elicit. There's also Durkin's compression test. You can see that here. You're simply applying pressure on the median nerve above of the flexor retinaculum for about 30 seconds. And the test, of course, is positive if you can reproduce those symptoms of tingling or pain in the hand, in those three fingers. A more recent test is the scratch collapse test. I included a YouTube link here for you to take a look at it. It's quite specific and highly accurate for carpal tunnel syndrome as well. Um, I think you do need to look at the video in order to learn to do that. And unfortunately, when I try to insert that video here, it immediately flips it into German, which isn't too helpful for you. So we'll leave it at that. Please do take a look. I put the QR code in so that you can get to it quickly on your phones. Okay? Now, my question to you, which test would you choose? Let me give you 2 seconds while I grab a swallow of water, and you can put your answer in the chat. Which test would you choose? Okay. Well, I'll tell you what I chose, and that is, in Anna's case, I chose the scratch collapse test because it is highly accurate in identifying this problem, and it is positive on the right hand, and very quickly positive and strongly positive, and is mildly positive on the left hand. I also performed a valence test, as we looked at before. It's positive on the right after only 15 seconds. It's positive on the left after 55 seconds. So it's also kind of a weak positive there. Okay. You might ask yourself, why didn't I do the other two tests we looked at? You really don't need more than 2 positive clinical tests. And in this case, I chose the 2 that are the most specific for this problem. My conclusions, the right hand appears to be more affected than the left, but the left is also affected, but to a lesser extent. Further assessment is needed to determine the extent of the impact on both hands and to guide our treatment. So we're going to look at some quantitative sensory testing here. We want to attempt to identify how much sensory function has been impacted. And we would have some options here to use a Q-tip or a cotton swab. You could also use a pin, a needle, or my preference would be a paper clip if you're just looking to define pain. We don't really poke people in the skin anymore. We probably never should have in the first place. But a paper clip, which is blunt, will not puncture the skin. And if you have nothing else, it's a better choice than nothing at all. Okay, you're simply checking for the ability to perceive pain. The 10 test, which might be new to a few of you, we'll take a look at that. The Sims-Weinstein monofilament test, which is something I use frequently, but if you do not have it, the Q-tip or cotton swab might be an okay solution. You could also look at hot-cold perception. If you had 2 test tubes, you could fill them up with warm water and hot water and cold water, and then ask if the patient can perceive hot and cold, which is fairly sensitive for carpal tunnel syndrome. And I've put down here 2-point discrimination. 2-point discrimination is extremely slow to react, so it will be quite a while until you would see a change in values that you can establish with the 2-point discrimination, and in which case you probably already have some atrophy. So it's not a good choice as a screening test for carpal tunnel syndrome. The basic sensor examination of the hand with a cotton swab is really not more than asking the patient to either close their eyes or look away, or to use a screen, and to use a cotton swab and ask them to identify if they felt it. Do you feel this, and where? Okay, so you're actually testing two things with that: the ability to perceive live touch and localization. You would note any areas that are reduced or where there is less sensation. There's also a link here if you wanted to take a look at how to perform this test. The 10 test is a newer test. It's coming up on 30 years old, but new compared to some of them. And it tests light moving touch, and it actually uses the patient as the barometer. So this is a very interesting test. You test both hands at the same time. First, you test the healthy hand, and you go over it with your finger and you say, this is the best sensation you could possibly have. We're going to give that 10 points. Now we're going to test your hand that's having difficulties, and you test the same finger at the same time. So you can see in this image that my index fingers are testing the patient's index fingers at the same time. You don't test a very large area. It's quite a small area. In this case, maybe from the PIP joint to the end of the finger, stroke it. The patient can have their eyes open. Their only job is to tell you, in comparison to the uninjured hand or the healthier hand, how much do they feel? If the healthy hand has 10 points, how many points would they give the sensation in the other hand? Okay, it does have a correlation with the Sums-Weinstein monofilament test. I have to say, over the years, I don't think it's the strongest correlation, but it is there. Okay, this is Anna's test results. I did the test results, the 10 test with her. And we know that she has it in both hands, so that makes it quite difficult. I did compare right to left. Right is clearly less than left, but left is also clearly less. So for the left hand, I adapted the test, and I tested the difference between her little finger, which is innervated by the ulnar nerve, and her other fingers that are innervated by the median nerve. And you can see in both of her little fingers, she rates that as good sensation. Also in the palm, good sensation, 10 out of 10. And then as we compare to that little finger, it is less sensation. Okay. We then went on to do a Sums-Weinstein monofilament test. Here, I don't know if you have these readily available. They're actually not that expensive in the world of test hardware. Most hand clinics would have at least a 5 or 6 monofilament test. This is a handy dandy little monofilament test that's easily transported. It tests light touch perception with a calibrated nylon fiber, so it always delivers the same amount of pressure. Okay, you have the description in your materials. You just test until the monofilament bends, then you've delivered the amount of pressure for that particular monofilament, and you do want to test kind of in the same spot each time. Okay, so here are Anna's results from this. Green means that things are all wonderful and normal, and that she can perceive somewhere around 50 milligrams, 50 to 60 milligrams. Blue means that there is a light reduction in perception of light touch, but many people who do manual labor would also just test it blue because they have much thicker callus on their hands. And you can see here, her 3 fingers are purple on the right hand, and that means that she already has a drop off in her protective sensation. Okay, she does not perceive the monofilament until it reaches 2 grams of pressure, so she's already having quite a drop off in sensation. The left one is more mildly affected, but the right one is more severely affected. I would like to make you aware that there are some new methods out there for Weinstein monofilament documentation. Sensation X is a free app online. You can use it to document. You still have to have the tool, though, to do the test. Okay. The next thing we'll look at for her is some motor function. We're going to examine her hands more thoroughly for atrophy, and we're also going to test her grip and pinch strength. Okay, so her motor function, we see no signs of atrophy. Her grip strength, she has a slight decrease right versus left, 2 kilos left, but we don't expect to see a big drop off because her long flexors are innervated before the carpal tunnel. Pinch strength there gets a little bit more obvious. There we have a drop off of about 2 kilos. That quite possibly may be due to some beginning decrease in motor function there, but we don't see any atrophy. We do see that lateral pinch is holding up better than our 2-point pinch and 3-point pinch. And with lateral pinch, you have a lot more activity from your adductor pollicis, which is innervated by the ulnar nerve. So therefore, you're not expecting as much of a drop-off in the lateral pinch as you are in the other two types of pinch, which require more opponent's function. Okay, so my clinician's conclusions here, her clinical tests for carpal tunnel syndrome are positive. We have a reduction in pinch strength. It's moderate. Her grip strength overall is slightly reduced. We have no obvious atrophy, which is positive. The right hand has a significant reduction in sensibility, but she still is able to perceive sensation. And the left hand has a mild reduction. So the right is definitely more affected than the left. She most likely has carpal tunnel syndrome and not just generalized hand pain. We're going to notify the doctor of the findings and we're going to start conservative treatment. And our next step in that would be to establish a baseline for her function and her symptoms with the carpal tunnel questionnaire. Okay, this is a self-administered questionnaire. It is available online and it is free, so you could use it. I don't know how many languages it's available in, but it's definitely available in English and German and probably some other languages out there. I'm just going to take you through basically you ask the patient to answer the questions, and they score it on 1 to 5 for each question, whether they have any problems at all, or if they have no problems, it's a 1. If they have a maximum amount of symptoms or problems, it's a 5. And here is the list of these. You have this in your handout, so we won't stay here too long. Anna's score is a 3.3 out of 5. You average the score for all of the items. So on her symptom severity scale, she has a 3.3 out of 5, meaning that she's kind of medium to severely affected. She's not quite in the severe category, but she's in the medium to severe category for symptoms. And now when we get to functional, there's some more items here. You also average this score for the items. She comes out at 3.6 to 5. So kind of headed more towards intense difficulty. It's becoming problematic. So what we're going to do for Anna, we're going to splint. We're going to give her some tendon and nerve gliding exercises. We're going to instruct her in some activity modification, have a look at ergonomics. And I will mention here that there's very, very limited evidence for treatment with modalities. And when I say limited evidence, it's not only limited, it's quite weak. So if you have priority in terms of treating this, go for the splinting, go for the nerve gliding, the activity modification. Don't waste your time on things like ultrasound and low-level laser treatment or shockwave therapy. Patients find that very attractive, but it does not have a strong evidence base for effectiveness. For splinting, we're going to splint her wrist in a neutral position. This maximizes the carpal tunnel volume. It minimizes, therefore, the pressure on the medium nerve because we've effectively holding it in that position in order to give it more space, okay, which should result in some decreases in symptoms. And one of the reasons we're going to choose night splinting is most of the time at night, people kind of curl up to sleep. That means they're holding their wrist in a flexed position, which we know there goes that increases the pressure on the median nerve. Okay. Some authors recommend splinting full time for 2 weeks and then going over to night splinting. Others recommend just night splinting. Generally, a course of about 6 weeks is recommended before you decide we need to do something else or we need to go on to surgery. There's great consensus in the literature that the wrist should be in a neutral position. Okay, we've issued Anna a standard wrist brace. We've made sure it's in a neutral position. We're going to instruct her to wear it nightly for 6 weeks. Do be aware if we choose the daytime wearing for her, there are studies out there that show that this increases the amount of muscle activity in proximal muscles as well as the extensors. I've highlighted them here in red. So I always instruct patients, if we do go for the daytime splinting option, to take that off several times a day when they're resting. If they're reading the newspaper or something, they really don't need to wear a wrist splint to do that. But preferably, my preference is to just instruct nighttime wear. We're also going to instruct her in tendon gliding. The purpose of tendon gliding is to get those tendons to slide by the nerve, okay? And not get stuck, not catch if there's any scarring or adhesions that have developed. We want them to glide freely away from another. What's really important with tendon gliding, you need to move from one position to the other, as illustrated here. The sequence doesn't really matter. You can do a straight fist, flat, then flat like that, then a hook fist, then a full fist, any combination of those. But what's important is that you go from one position to the other, and it's a small cycle. Okay, so one cycle is one exercise. We're going to instruct her to do 5 repetitions 5 times a day. It's suggested that nerve gliding is beneficial for nerves. It facilitates blood flow to nerves. It optimizes axonal transport. It should hopefully maximize or lengthen adhesions of the nerves within the nerve bed. And for that reason, we're going to also instruct Anna in nerve gliding. When you go online to look, and I'm sure you do that, you can see all sorts of versions of nerve gliding for the median nerve. In this version, it's a very simple version. You'll note that her head is tilted away from the arm that is impacted, in this case, the right arm. The head is tilted away, but the hand is relaxed and the elbow is relaxed. The whole purpose here is that you're decreasing the tension on the nerve here, and you're increasing it there, and thus getting it to glide a little bit that direction. As she then straightens her elbow and extends her wrist, her head should come over to that same side in order to get that nerve to slide back and forth. Okay. And if you're instructing patients to do that, I generally start with maybe 10 movements back and forth, and watch what happens over the first couple, 3 or 4 days. If the symptoms get worse, then you want to decrease the amplitude of movement. It could be a smaller range of motion, maybe not fully extend that wrist, maybe stay with the elbow bent so that you're not asking the nerve to make such a long excursion. Other suggestions come from Butler, who created some practical suggestions. Not everybody can understand nerve gliding. It's a little bit weird, the movements. He said, well, why not just do some practical movements? He suggested, for instance, balloon padding as an exercise. You don't actually have to have a balloon, but you are bending and straightening the wrist back and forth, and that's getting that nerve to glide. Or going from the position where your hand is down at your side and you come up to look at your wrist, as in this other example. That's also actually a nerve glide. Okay. Important here, gentle movements. The goal is to get the nerve to glide back and forth. It should not hurt. And I think one of the trickiest part about this is people will do them and they'll say, well, I don't feel anything. Well, you're not supposed to feel anything. When you don't feel anything, you're doing the right thing. You don't really want to irritate that nerve. Okay? Okay. In summary, conservative, non-surgical treatments are generally very safe for mild to moderate carpal tunnel syndrome. This is from a review in 222. The effectiveness of different conservative treatment varies, and additional high-quality research is needed. Okay? We want to instruct the patient to avoid repetitive finger and wrist motions. We want them to take frequent breaks, alter the type of activity done in one sitting, avoid tasks where you're banging down with the hand, do it in an adapted manner, pad things so there's not as much force against that carpal tunnel. For Anna, we're going to suggest that she maybe explore doing some pacing. Instead of cooking the entire meal at one go, maybe she can prepare vegetables earlier in the day, and those are all chopped and ready to go towards the end of the day. At work, she can ask her boss if she can change tasks every 60 to 90 minutes. These are some practical things. Our follow-up will be then when we see Anna back to review her exercises, check the splint fit, ask about symptoms. She doesn't really need to come back more than once every 2 to 3 weeks. We might want to reevaluate with the Boston Carpal Tunnel Questionnaire at 6 weeks. If we see no improvement at 6 weeks at all, then we probably would want to refer back to the physician for further evaluation, for instance, nerve conduction studies. In summary, you have this slide in your handouts, and I'm going to skip really through reading all that because I do very briefly wish to talk about what happens post-surgically. But I do want to bring home the point that if atrophy is present or sensory loss is severe, then this does not belong in our hands as therapists. This should be referred back for perhaps a surgical release. The median nerve is so incredibly crucial to hand function that if we already see atrophy and severe sensory loss, we don't want to waste any time with conservative treatment. If it is a mild to moderate case, it can be treated with therapy. Okay? If you do see a severe case, it may take some time to get that sorted. It's still a good idea to provide splinting of the wrist in neutral, only as an intermediate measure to prevent further damage. Okay? On the what if scenarios, I did want to bring up the fact that not everybody has splints in the cabinet that they can just get out and hand to a patient. Some options, you could consider discussing with the patient, do they have anybody in their family who does sports? Do they maybe have some wrist guards from a sports store that could be adapted? You could also consider taping, but taping for this varies. And I don't find taping super effective long-term because it does have a recurring cost and it is pretty tough on skin. If you have really good solutions for this, I suggest you write them in the chat. Another solution might be just to make a plaster of Paris, not a full cast, but an actual sort of splint, making sure the wrist is in neutral and use an ACE bandage around that. But I think that you all have often faced situations where you don't have as many resources or you can't make your resources stretch to everybody. So maybe you have some good ideas on how to help splint that wrist in neutral. So types of surgical interventions for carpal tunnel syndrome, open surgery, endoscopic surgery are basically your two choices. And one of the questions you all asked before the course that you wish to have answered was, should you splint them post-operatively or not? Should you immobilize them? And the simple answer is you most definitely should not immobilize that wrist. And I will say that even here in Switzerland, that runs a little bit counterintuitive for some patients. They feel like I've had surgery, I must surely need to rest. And sometimes, occasionally, an older surgeon will say, no, we're going to rest it. But actually, there's no evidence that supports that. Indeed, most of the evidence, and here's a short review of a few studies, looked at that question specifically and found that patients did much better if they kept moving post-operatively, okay? So really do not immobilize them, get them to move. That doesn't mean they couldn't have a bulky bandage and move a little bit more in a limited range, but they should be moving, okay? Just to make you aware, usually 70 to 90% of carpal tunnel release patients have excellent results. But the longer the carpal tunnel has existed, the longer the compression has existed, the more likely it is that you may have some uh, residual symptoms. It can be a chronic sensory disturbance. Then that sensation doesn't fully recover or is still kind of numb. Or it could also be that you're having a very difficult time getting that opponent's muscle to function again if it has been highly atrophic. There are a few cases where there are poor outcomes, and I'd like to point your attention to one of the most common complications, pillar pain. About 28.6% of the complication rates is attributed to pillar pain, and you might be asking yourself, well, what the heck is pillar pain? Pillar pain refers to pain in the thenar and the hypothenar eminences. And if we go back to thinking about where the origin of those muscles are, once that carpal tunnel flexor retinaculum has been cut, you realize that those muscles lose a part of their tension that holds them in place. The flexor retinaculum is still there. It's just cut apart back into, but the tension that's holding it is suddenly released, and it may take quite a while for those muscles to shorten and realign themselves, and that can be quite painful. And it does have a name. It's called pillar pain. There's not a lot of information in the literature specifically on how to treat pillar pain. My experience is massaging the thenar and hypothenar intrinsic muscles can be very helpful. I instruct patients to do that. Here, I would say ultrasound and paraffin baths can be beneficial. Probably a large extent to placebo effect, but patients do think we're doing something for them, and that seems to help with the pain management. Elastic wrap bandages that provide a little compression there can feel very good. Some gentle vibration could be the end of an electric toothbrush. I even had a patient who said, oh, it just feels so good when I hold my mixer and let the mixer run. I don't actually mix anything. It just feels so good there. Kinesio taping may help, and probably the biggest factor that's helpful here is time. So with that, I've come in a tad late, but close to the deadline, Nicola. So I will stop here for questions.
Thank you so much. That was a really helpful presentation. Okay, so we do have a few questions. The first question is, what exercises do you recommend post-surgery?
Actually, back to the same thing as we do before surgery, tendon gliding and nerve gliding. But I would be very careful on the nerve gliding not to be too extreme. Start with a small amplitude and gradually work up. If you have weakness, you may want to give them some strengthening exercises, particularly pinching, that sort of thing.
Okay. And then someone wants to know, isn't there a possibility of bowstringing if the wrist is not splinted in neutral after surgery?
That's an excellent question, and you would absolutely think that that would be the case. But in 40 years of practice, I have seen many, many cases of released carpal tunnel, and I have never seen a single case of bowstring.
Okay. And then what if a patient's leisure activity that they enjoy is causing their carpal tunnel and they don't want to stop doing the activity? What do you recommend to that patient?
That, I think, is one of the most difficult situations out there. I try to work with them on adapting their leisure activity. I try to work with them on maybe introducing some pacing to the leisure activity if they absolutely refuse it to give it up. But sometimes you have to be quite blunt, and you simply could say, if you hit your head on a wall and you got a headache from it, would you keep hitting your head on the wall? Because sometimes it really is the leisure activity that's doing it.
And then there's a therapist who's noticed that some of her patients say that they have immediate relief with wrist extension. So do you think that's a helpful method to relieve pain?
I think if they have immediate relief, it's probably just that they're changing the position. If they were flexed and they bring the wrist up, they got that nerve to slide in there. There's really no evidence that says it's a good idea to splint an extension because we know it narrows that tunnel in there. So I truly couldn't support doing that. But I could imagine if you're down in flexion and it's getting sleepy, if you go the other direction, yes, it might provide relief immediately, but it's not a good position long term.
And then do you find that some of your patients experience hypersensitivity, and how do you manage that?
Hypersensitivity post-operatively sometimes does happen. Hypersensitivity for carpal tunnel, sometimes in a very, very early phase when the nerve is quite irritated initially, because it's tight in there, you can see a very brief period of hypersensitivity, but I very rarely see patients in that phase. Post-surgically, sometimes you do see that, and you will often have to desensitize fingers. Once you have managed to do some desensitization of fingers, you will often find that their sensation is kind of poor below that level of hypersensitivity.
And then if you have patients who have carpal tunnel during pregnancy, what sort of time frame do you expect for the symptoms to resolve following delivery?
Usually, that's a tricky question because it also has to do with breastfeeding and how long women are breastfeeding, and also they're holding babies in there and not such a great position a lot of time. We do see a lot of moms with carpal tunnel problems that persist after the birth of the child. We work quite heavily with them on how to hold a baby so we're not bent in that tight position, which is quite a normal reflex as a mom. Generally, I would expect it to subside within about 6 months, but if it was somebody who was doing lots and lots of breastfeeding or the child was lots and lots of baby carrying, it could take a lot longer. And then the question might be um, really worth exploring with the surgeon. You'd have to carefully monitor that nerve. How bad is the damage? Because it's not really worth having long-term damage. Then it
Mm.
probably should go to surgery earlier rather than later.
Okay. Um, and then just one more about differentiating between carpal tunnel and de Quervain's. Do you have
Ah,
a quick way of doing that?
yes, absolutely. I mean, I'm not looking for sleepy fingers with Decker veins. Decker veins is primarily a problem in your first extensor tendon compartment. You can try the what test where you bend your wrist and extend your fingers. I guess you can't really see that here very well. And you press on your thumb, and that's called a positive what test. If you get shooting pain there, you can do your general Finkelstein's test there. But the biggest differentiation is I'm not expecting to have a decrease in sensation in those three radial fingers.
I think that's all we have time for. If you could stop sharing your screen and then I can close our presentation.
Absolutely.
Okay, so thank you all for joining us this evening. And thank you to Sarah for your amazing presentation. Okay, then our next webinar will be on the 2nd of September. The topic is complex hand injuries, what to do first when everything is hurt. So we'll hope we will see you there. Okay, so then you can follow us on social media, you can subscribe to our YouTube channel, you can join our mailing list, and we hope to see you in our webinar next month. Thank you.